Hello, everybody, and welcome to the Bad EM podcast. My name is Daniel Still, and I'm your host. Bad EM stands for Brave African Discussions in Emergency Medicine, and is a platform we use to try and find African solutions to African problems and share good ideas. This month's episode is Dr. Tshegofatso Maimela, who is a public health specialist and the head of the Information Management Unit at Charlotte Maxeke Hospital in Joburg. She has a lot of experience in health management systems, both in private and in public. And in this episode, we will talk about how data can be used to increase efficiency, how to bridge the gap between downstairs provision and upstairs management, and then we dip our toes into the deep waters that is the NHI, and how it will or can affect emergency medicine provision in South Africa. For clarity, this episode was recorded before President Ramaphosa signed the bill on the 15th of May, but it doesn't actually affect our conversation that much. As always, opinions shared represent myself and my guest in a personal capacity and do not represent any institutions that myself nor my guest represent. And then I apologize for the background noise. There were a few Joburg Hardy-Dars towards the end of the podcast who also wanted to make their voices heard. In our show notes, you will also find some of the acronyms used in the show that are spelled out for you, some useful links to information regarding the NHI. The NHI website itself is actually really good, and you'll also find more of a biography about Tshegofatso and the work she does and some of her personal projects that she's working on, as well as a link to her LinkedIn profile where you can get in touch with her. Welcome to the show, Tshegofatso, and would you start by just introducing yourself and giving us a brief rundown of your professional career so far?
Okay, thanks, Dan, and thanks for the invitation, and I'm really excited for our conversation. Okay, so my name is Tshegofatso Maimela. I am a public health medicine specialist, having done my my bachelor degree, then my M.Med within the WITS circuit, and I'm part of the College of Medicines of Public Health Medicine. In terms of my career background, I've moved between public and private quite often. I think we'll talk about that later. So after ComServe, I went into private practice for some time doing ED or emergency medicine part-time. Then I went back into doing my reg time, because that's when I figured out I love systems and management and all sorts of things and programs. Since then, I have been the head of Information Management Unit, first at Steve Biko from 2019 until 2021, and I transferred back to Charlotte. I live in Joburg, so the commute was the issue. And then I've been at that position since 2021, the 1st of Feb. Yeah, that scope of work is very busy, full of a lot of information. Largely, it's information management. That's really the scope of work that I largely do. So yeah.
For those of us outside of the public health sphere, what does information management actually involve, and what do you do on a day-to-day basis?
So information management at our facility, and in fact, I'll speak around the organization, which is the Gauteng Department of Health, pretty much looks the same. So we all have patient registration systems that collect information around patient movement. So admissions, discharges, transfers, moving across different wards, etc. Those are inpatient data inputs. And then we've got outpatient department head counts. So how many new people are coming in, how many follow-up have we seen. We also have the pharmacy sort of head count, how many people are coming into the pharmacy, what kind of scripts are they, not the detail of the scripts, but how many scripts are they having per patient. And so the function of the Information Management Unit, our team, and the Monitoring and Evaluation Directorate is to report to our managers, our clinicians, and the provincial department around that patient activity. So how many people have we seen move through the hospital on a monthly, weekly basis? And, the proportion of new versus follow-up, etc. Across all the disciplines in the hospital. So that's largely the function. It's growing. It's ever growing because of, new expectations around the legislation changes, and I'm sure we're going to talk about NHI and stuff. But really, it's a tracking function, and hopefully a business intelligence function of the hospital and of the organization as a whole.
Is the data you collect at the moment used retrospectively to inform decisions, or is it also used in real time to help make patient movement more efficient? With, for example, the amount of patients waiting, amount of beds available, discharges pending, etc.
Yeah, I would say we're somewhere in the middle between that. So traditionally, we've had, I suppose, patient record systems that allowed us to pull data retrospectively, so we could speak about what's happened over the last month. And I think the department and a lot of organizations obviously value real-time data, so that's where we're transitioning into. Obviously, also in light of moving towards a regulation system where that kind of data is available in real time. There've been efforts, I think, the past, since COVID, I think it was, where we've tried to implement systems where we can get real-time data, but the truth of the matter is that it's not real-time per se. I mean, it might be 4 hours, 5 hours of who's sitting in which bed, etc., and who's getting discharged and who's being transferred around. So that data is real-time to an hour, but not live. Yeah, so we are trying to move into an environment where we have live data, so anyone can sort of open their systems or softwares and be able to see in real time, okay, where are the beds available, who's getting discharged in the next 30 minutes, etc., etc., so that we can actually have more efficiency in the hospital.
I actually read an article in The Economist recently about how some hospitals around the world, with the help of data systems and artificial intelligence, are creating almost a flight deck or a control tower to gather movement data and help move people around the hospital quicker, which has shown to vastly improve efficiency and even clinical outcomes. From your experience, would you say that good data equals good systems and good clinical outcomes?
Absolutely. I think if we're all looking at the same information in real time, that's completely available to everyone in services, that should actually be an enabler of efficiency more than anything.
In terms of efficiency of data, one of the questions I've often thought of is the file number situation in South Africa that varies so much across different provinces. I know in the Western Cape and in Gauteng, as far as I know, there's one file number per patient, which can be used across different hospitals and different platforms, including NHLS, which decreases a lot of redundant workup, a lot of efficiency in terms of finding data, essentially. And in the rest of South Africa, as far as I know, there's not one file number per patient. Why is this such a difficult problem to fix from somebody without any public health background or any IT background? It seems quite easy on the surface.
So, yes. So the thing about the Western Cape that I think the whole country really does appreciate is that there's been some political and operational stability for over 2 decades now in the Western Cape. And because of that, not only have your services matured, but your operational corporate back end has also matured over time. It's the reason the province knows how to code better than every other province. It's from a provincial perspective, they've got a unit actually that does the coding, the diagnostic related groups coding, and they've done this piece of work for some time now. It's the reason that they have more advanced tracking of patient activity and their cost centers. And I'm talking about public facilities. Obviously, all private facilities have to have this for billing. But certainly I know that Western Cape has been doing cost centers and functional business unit, corporate as well as operational governance and mechanisms for some time now. So yes, your experience and your reality is completely different to how the other 9 provinces function. I do know that to some extent, KZN as a province has improved sort of their paperless approach. I don't know if they are still maneuvering the issue around the lab test or a single patient identification number that then is linked to the patient journey across various public service providers, NHLS being one. But up until recently, when we started implementing the provincial HIS solution, we were also struggling with the same thing, probably as the other provinces do. If there isn't a centralized data system that allocates a patient number so that you can see patient journeys across facilities, but within the same province. And so, yes, we were understanding that the project of an HIS implementation, health information system for HIS implementation, was going to require a lot of the agreements that need to be put in place. And these are corporate agreements and risk-related agreements, and who takes liability if there are data leaks between organizations. So the Gauteng Department of Health had to then go to NHLS to probably create this memorandum of agreement around how our HIS was going to then bring that in. That's the back end sort of stuff. And the reason it takes so long is because that corporate part, I think, requires the right people in the room together, rather, agreeing on the objective, the scope, the cost of the scope to implement something like this. Who's going to fund it? How is data sharing going to work? How is data protection going to work? How is liability in the event of an incident related to data and patient information going to be shared? How is that liability going to be shared, if at all? So those sort of agreements, usually in the back end, are what take a long time. But once the agreement has been made, then the operability part, so this is the technical ICT thing. The ICT people just speak to each other and make sure that the ICT language is aligned, and the ICT communication between the systems can then communicate to this one PMI number that we have. Another consideration on why it takes so long, one of the things that the Department of Health did, I think, a couple of decades ago, trying to get to the point of NHI and a single what that's going to communicate across nationally, like an information system that's going to be able to communicate nationally, is they put together a policy framework around health information systems, their design, and the fact that they have to be developed with interoperability in mind, meaning that you can plug in a solution because the specifications of how it communicates with other solutions is clear in that policy document. So there has been legislative regulations and frameworks to try and make sure that people who come up with new ideas, new apps, new this, new that, however they configure their solution, it should align to that policy framework. Otherwise, look, they could implement it if it's just a local thing, but if they want to try and plug it into something larger, the ecosystem of, for example, a national system, it must comply with those specifications. So sometimes, developers do start something, et cetera, and they do things, and then you just think, oh yeah, no, you can just plug it in. And they didn't know that there actually is like this whole policy framework, and then they have to go and reconfigure things or start from scratch, et cetera, to align it so then they can facilitate or scale that solution into something that can be used at a district, at a province, or even at a national level.
So to go back to your personal career, what is the reason that you went into public health in the first place? And do you feel that you are implementing the change? Or do you think you have the systemic influence on a level that you initially imagined? And do you do the work that you initially thought you would do?
Okay, let me start with the first one. So what led me to public health was, I think, being in services is completely different, obviously, to undergrad training. We experience quite a reality check when we are in systems, especially during internship and ComServe. There are resource matters, etc. But even in resource confined spaces, I think there are functions of, I think it was health services and management stuff that I really didn't understand coming into services, around how we recruit, how we decide a budget, why do we choose, why does pediatrics get something and not surgery, etc., etc. So how does that decision making happen? And in fact, that's why I'm in data, is because I wanted to understand what informs decisions around services, right? And so before coming into public health, I did go into private to see if the experience is any different, because I just wanted to make sure, that I didn't have a skewed view of public and private. I think there's stuff in both systems where efficiencies can be optimized, and then I had to think about whether or not I wanted to do, like an MBA, if I'm thinking around the business or the administration largely, or if it's a systemic thing. And once I got clear about the systems part that I needed to understand, that's how I went into public health medicine itself, the REACH program. And then to your second question around whether or not I'm in a space where I feel like I am impacting change, how I thought I would say yes. But I will say that has been informed by my experience in public service. So I think it's part of the training. The training actually shows you what level of decision making happens across facility. Well, even the consultation, all the way up to whatever national, regional, global decisions, right? So that also sort of altered my expectations around what's possible and what isn't at every level. So I needed to be clear about how to position certain requests. I mean, certain things can't be done at CEO level, at HOD level, at province level, at national level. There's certain decisions that you're quite clear now, or well, at least I am now, that I won't try and effect change at a facility level that is beyond the scope of the facility to approve, And I think that's part of how I've negotiated understanding whether or not I am impacting. So the thought is that within the organizational authority, yes, I think I am, without question. So I'm able to use the information and the directorate where I'm functioning to support my peers, which I think is really essential. My peers, my HODs, my whoever's looking for the information, to be able to use it for service delivery decision making and possibly strategic decision making. And then I make sure that the data is of a reliable quality under the data governance structures and mechanisms that we have to comply to. The Auditor General does make sure that we are reporting the right things. So to make sure that the province is comfortable with the numbers that we're reporting, that we're undertaking very clear governance processes and making sure the data is reported accurately and honestly. So to that extent, yes. And I guess if I was sitting in a district level, I would be thinking around how does that translate at district level. And if I was thinking at province, et cetera, I think, I'm not sure if that's the experience of colleagues, but for me, I certainly feel like I have enough agency to really live the whole public health support for service delivery, at least at the central hospitals that I've been at and the one that I'm at now.
So leading on from that, you worked as a clinician for a while. Do you think that this has benefited your current work, or do you think that data analysts from a different sector or professional background,
Yeah.
for example, finance or management consulting,
Yeah.
could come and do a similar job in a healthcare setting?
Yeah, no, yeah. I definitely think if there's a desktop exercise, any consultant can really probably address it. If the questions are nuanced around an implementation approach of anything into the services, I think it's really important for doctors to be around the table, so that the experiential aspect is brought into the conversation. I mean, corporate services, corporate industries, and medical industries are completely different. The regulation is different. The hierarchies are different. I haven't seen any sort of circular structures around medicine, even as certain organizational structures have changed. So it's very hierarchical, and I don't see that changing soon. So you need to really appreciate the decisions that an intern can make versus a head of department can make in your implementation design. Whatever you're recommending, you need to know the system very, very well, because otherwise you will design something that won't function in real time or in services, whether private or public. And so I think being a clinician is really essential for going to public health practice, well, at least public health medicine, because there are various public health practitioners in the areas of professional expertise. So you've got physios and ODs, etc., who've also gone into public practice, and so they bring that lens into the larger either programmatic or policy discussion, which is essential. So when it comes to public health practice, you need as many different views as possible so that everyone can actually bring in those insights around what practice looks like. And then that insight is then translated into either a program or an implementation strategy or a policy position, whatever the objective is. But for me, and in fact, I still enjoy being in the services. And that's why I think I enjoy being in the hospital, is because I can still see the services. And if there is anything that is brought either top down or bottom up, I can at least engage with it and say, this is going to work going up or down, and then say, this is not going to work, whether it's going up or down, because there's a very clear understanding of what the real and lived experience is within the facility, at least at my facility. And we engage with other facilities often enough monthly on structured meetings, and then other times with calls, being on call, being clinical management on call, etc., where you do appreciate some of the day-to-day facilitators and barriers of service provision. So knowing that I understand the services as best as I can, and I think we talk about them on a daily basis, in fact, allows me to express this public health mind in a very strategic and targeted way.
With regard to service provision from a bottom-up level, I read a quote recently that goes, "If the room where decisions are being made does not smell like the room where decisions are being carried out, then we're in for trouble."
Yeah.
Now, obviously, this can be applied across many different settings or sectors, but can literally be applied to a lot of healthcare settings, as sometimes the room doesn't smell very good at all.
Yeah.
And I know a lot of junior doctors working on the ground have little or no understanding or connection to any administrative decision making that is being made or management systems that are going on in the background. So how do we bridge that gap and improve communication between upstairs and downstairs?
Dan, so I mean,
An easy question.
not. It's a lovely question, though. So, like, the simple answer to that, like simple, not easy, but simple answer is around communication. One, around expectation management, around appreciating different people's roles in the entire ecosystem of the health system. It is very complex. It's as complex as the human body. It is complex. And if you're dealing with an HR issue, for example, you need to make sure that facilities is on board. You need to make sure that, if you're a doctor, that nursing is on board. If you're a nurse, that quality assurance is on board. So there are many moving parts in any decision that impacts the health system. That's the first thing. And I think there is room to learn, I think, from many of our areas, with implementation and even with general service delivery, that as levers are moved and decisions are made, that communication and expectations are managed at the same time. Because you can have an idea that something's going to be implemented like this, and it may be agreed upon from the beginning, but then it ends up looking like something else. And if you don't take people on that journey, that's where you get this disappointment, frustration, disillusionment around whether or not this entire system works. I've had registrars, usually when they come in specifically, they usually start at the hospital, and they fully appreciate how hard administrators are working to actually get the services where they know they should be. And I think that sometimes disarms them, because you, as you're saying, when you're in, you're dealing with the day-to-day lines and the complaints and the et cetera, you're thinking, oh, I'm doing this all by myself, but you're not. The truth of the matter is, many of the clinical heads of departments I've worked with honestly demonstrate exceptional leadership, knowing that they have to interface between the team, the aspirations clinically of the unit, and everybody in it, as well as understanding they have to manage the corporate services part of it. And then similarly, the corporate services team is trying to negotiate with higher levels of decision making so that the facility can get what it needs in order to be able to deliver on its mandate at that level. So the simple answer to that is, if we were able to communicate better and manage our expectations better, I think there'd be a greater appreciation of how everyone is working together to try and move the needle a little bit towards equitable, accessible healthcare. I think it's also a function of leadership. So you do see stronger leaders and stronger communicators able to sort of manage that. And I think that's just a quality that either is nurtured over time, or you start to appreciate, or if you're willing to learn from others' successes, that you can draw from their way of communicating with the team to make sure that everyone is sort of aligned with where we're going, even though there are admittable difficulties sometimes, particularly in the public sector with resources or efficiencies.
With the concept of communication and expectation management, I think it's a good time to change our focus to a conversation about the NHI.
Mm-hmm.
If you look at the media coverage of the NHS in the UK at the moment, there's a lot of negative criticism about the NHS in general, but it's difficult to find an article that doesn't mention the waiting times in emergency units around the country, around the UK, as a big factor in the situation or the displeasure with the service. And it seems like the media and the public latch onto it as a proxy for the status of a whole healthcare system, which is, of course, a lot more complicated than that.
Yeah.
But how is the NHI planning on providing emergency care to South Africans? Most of the discourse so far has been around primary care provision and specific service allocation when it comes to beds and imaging and consultant services and consultant consults, but I haven't actually read much about emergency care so far.
That question is really hard to answer, simply because we are still waiting to see what service packages are included within the bill. So until we have that, really, there isn't a clear way to answer it. We are suspecting, for example, people come to the emergency department to take out stitches or to, take off casts, for example, but that can be done in a primary setting. The question is, will the bill say that it has to be done in primary setting, or will the bill allow for an emergency center to do that? So I think it's as the articulation of what the services really are and where the bill, or if it's the act later on, suggests the scope of practice should be sitting here, then I'd be able to answer that in a more honest way. But for now, there is a clear distinction between primary care being or district health services, which could include, it depends on the level of care, I think, for me. Like a district hospital is included in district health services, for example. A district hospital being a hospital less than like 150 or 250 beds. That would be part of the contracting that's related to primary care. Whereas more, regional, tertiary, and academic sort of centers and more complex private health sectors, hospital complexes, they would probably contract differently than the district health service sort of idea. And so until we see, either pilots doing this or reporting how it's done, it's really difficult. We're just theorizing at this moment around how that would look. But I think a key aspect for us to be able to now think around how we plan our practices, our care models, is to understand what that minimum care package is. And once the fund describes that, I think we can probably populate everything else.
Sort of like your prescribed minimum benefits on a medical aid package. So one would have a defined service being offered, and then you need to get that, and that service package is offered at a certain place, at a certain level.
It's exactly like that. So I'm saying without knowing what the scope of care is, we can't plan around the care pathway at all. And which parts of it sit in district or primary care and which sits in hospital services, and how to then design movement and, various care models to be able to meet a condition that would be well serviced across both sectors or both platforms, whether it's both sectors is private public, and then both platforms is district health services and hospital services. So, I'm just going to use an arbitrary condition. Let's say CA cervix. Let's just use something as simple as that. Prevention is pap smears, etc., etc. Does that mean that that pap smears are only going to be paid for at district health service, or is a gynae who does a pap smear also going to be remunerated for it? That's the question that the bill has to answer. Similarly, if there are, changes that require now more advanced services, at what level will the bill pay? Because currently, even in our regional hospital, our tertiary hospitals, we do have
like a hysterectomy or something,
anything like that, a colposcopy or a hysterectomy, etc., etc. Depending on the scale of intervention required. At what level will the bill say, okay, it's best at regional hospital to do a colposcopy, for example, and then hysterectomies maybe happen at another more expensive area, which is central or whatever. I don't know. But the bill has to define that across possibly all conditions so that everybody knows where they support the patient journey and the interventions that are required for best health outcomes.
So once you have your service package defined, if a person needed emergency care, they could go to either a public or to a private hospital where a practice that is registered with the NHI would be running the emergency unit.
Yes, the closest.
And offering that service package that is predefined, and then the NHI would reimburse whichever unit based on whatever service that they rendered. Is that correct?
Mm-hmm. The idea is because the issue is access, it's the closest, and then the bill would be paying the same amount across the different institutions.
To put you on the spot, do you think the NHI will roll out? And if so, in what form and when?
I think I think it has to. I think it doesn't have, I don't know if, so it's not gonna happen the way it looks in the bill. Like, I mean, if it can't happen like that tomorrow, there is a journey to walk, there's, and I think we say this often. I mean, my colleagues, we know it's going to be a journey. It cannot happen like a flip of a switch. We would collapse the system. So there is an appreciation, I think, and maybe it needs to be better communicated from as many of us who understand and appreciate this, that there's a journey ahead of us. And we have to walk in tandem as we articulate and actually sort of set in stone certain practices. Good, that's it. Then we move on to the next chunk, over decades, years and decades, I think. And the I think the difficulty around NHI is that practice evolves, as you know, science changes, all the time. So this evolution of science also needs to be taken into consideration as people conceptualize what these implementation milestones will look like for practitioners, for providers, for patients and their ability to choose. It has to be discussed and appreciated all the way around so that that whole movement happens as a collective. But I think from a human rights, and I think everyone appreciates that we need to have a system that actually produces better health outcomes for everyone, and that's really the heart of it. The mechanism at the moment is a financial model, and there will be discussions and debates around whether or not that's the most appropriate one. Is there another one? Don't know. But that's what we've got. And I think if you are looking, and I think I'm saying many, but many of the conversations I have with colleagues is that NHI is almost pushing us to think around access, think around efficiencies, effectiveness. Even if NHI didn't go through, we still have to solve these problems because we've got access problems, we've got quality problems, we've got safety issues, we've got efficiency problems across both sectors. And so we still have to solve those whether NHI comes in tomorrow. So we still have to have the conversations of how do we improve the patient care continuum, what kind of models work best, that don't keep people broke when they access private GPs or private, hospitals. We have to have conversations. Otherwise, it becomes just a political discussion as opposed to a health system improvement. And I think everyone in the healthcare system is invested in at least that. So there's still work to be done, whether it's articulated, in black and white on the paper and on the bill and the act, etc. We still have things to improve. Communication across disciplines, across management doesn't need an NHI. It just needs strategic and functional leadership to do that. We've seen it happen in both private and public sectors. There's certain, units that are so strong. And maybe the issue is just supporting training, leadership, etc., reporting, governance, etc., capacity building. Maybe it's just an issue of capacity building. But I think the bill is now pushing us to say, how do we do that in preparation for whatever the payment or the reimbursement mechanisms are going to then be.
You said that the NHI cannot happen overnight because the system would collapse. Do you think a staggered implementation approach would be feasible in terms of the service packages that are provided? For example, initially there's a NHI for obstetric care, and then one rolls out a NHI for TB and HIV care, and then mother and child care, etc., etc. So not all at once, but perhaps funding packages based on service packages as they are released.
Yeah, I think that's exactly it. Until the service scope is articulated, and I think probably there's a lot of data that the department and the ministry has around how they're going to identify where the burden of care is and what is the most cost-effective care that the fund can actually afford. So if they can find some sort of an agreement at that point, then that's probably going to be what they articulate to be the scope of care in the first couple of years or decades, etc. And then as it matures, then perhaps we add on to that. Whether it's across all demographics, I don't know. It'll be informed by the data that I assume they're looking at. But I can't even begin to guess how they're going to go about it. I don't know how they're going to go about it, but I know it probably is going to be informed by their data systems, because there's decades now around what is happening at primary level, what's happening at tertiary level, and more. Even in private sector as well, they've got access to that data. So the question is now, okay, what's affordable? Really, what can this NHI fund afford, and then start there.
From somebody that has worked in private and public, you obviously have experiences of how both settings work. I think a lot of South African people who access private healthcare at the moment are a bit scared of the NHI, and that's purely because of their perception of quality of care that they're going to receive in a publicly run facility. And I feel like in a lot of situations, the medical care offered in the public system is actually a lot better than the care offered in private. And this might not be the perception of care based on your care experience, so to say, which one can argue is actually more important. But
Right.
how are we going to go about reassuring the public that the medical care and the medical treatment that one can receive in the public sector is actually very good, and which is also dependent on the hospital that you go to, or the clinic that you go to, or the area which you live. But how do we reassure the public that the public healthcare system can actually be quite good and is actually quite good for most of the time and in most situations?
How can we reassure the public? I think there's information out there, both published and grey, so magazines and reported sort of experiences in public health institutions that really are, they showcase what public service is in most cases and can be, where there are gaps. I think I don't know if it's reassuring the public more than creating an enabling environment where we do showcase that. I just don't think. I think the only time you hear about public health facilities is when things go horribly wrong, but you don't necessarily hear on an ongoing basis when things are going very well, and there are these really unique areas of expertise in these tiny pockets. Not always tiny, but these small departments are doing exceptional work, and nobody's saying anything about it. At the moment, I think both public and private sectors are having this whole Office of Health Standards Compliance, making sure we have the same standards, etc. It would be great for, I think, the public to see as much of how well most facilities are performing. In terms of their governance and their day-to-day procedural operational things are in place. Not everywhere 100%, but where there are those particular test cases and those activities have taken place, and where certain facilities have actually institutionalized their own self-assessments, for example, to make sure that they are improving. Some people aren't just happy with an 80%. People want to go to platinum status, and they're pushing and they're pushing and they're pushing, which is fantastic. It tells you that there are people in the system who aren't just trying to get through the bare minimum. They aren't. They're really pursuing excellence. There are Service Excellence Awards, I wish could be broadcast. It's a national thing where there are awards given to units that have done exceptional work. And you just see that, we've got great people in the health system, really fantastic people. There's a lot of ingenuity, innovation. There's a lot of public-private partnerships, even if it isn't at scale, but in various pockets and various units that have been able to allow better access, better resource distribution. And so examples of that not only, I think, would provide that reassurance that you're talking about, but could also spark other people in maybe more remote settings to start thinking around those ideas. Is something like this replicable in my place where, yes, the resources aren't there, but maybe this sort of thought and that sort of mechanism can do something different. And I don't feel hamstrung by, what I think isn't moving, just to watch how people move certain barriers through and, collaborate with organizations you didn't know existed and were providing this kind of sponsorship or whatever support. So I think it's for our public, health. I think everyone really to just showcase what we're doing. There's really great work being done. Really great work. I think it's just a matter of just disseminating that good news, putting it out there. They're great people, great people, great system, great programs, great innovations worth sharing. And I think even, it might even invite private sector to start thinking around how do we best partner with this kind of thinking or that kind of model, because it aligns either to the business or something else. But I think there are a lot of opportunities. If we're looking for opportunities, there are a lot of opportunities. But if we're looking for complaints, yes, we are going to have just as many. So I don't know. I'm a half glass full sort of person. I look for the opportunity and see how we can get it through.
That's why you're on the podcast. Last question. If you had a magic wand and could get one thing, i.e. an NHI that magically worked tomorrow, or a redistribution of services and facilities to non-urban areas, or more hospital beds, what would you wish for? What would you want in South Africa?
I wouldn't. More hospital. Okay, no more hospital beds. We've got enough. We've got enough in private. It's just a matter of public-private partnerships, etc. We've got enough. We've more than enough. My magic wand would be that I want to think about this answer. There's one part of it. One part of it is an undergraduate training. I think the sooner we start capacitating undergraduates across all service provision on the administrative demands of health service delivery, I think you have better managers as they grow, right? I think we deal with the management and organization and admin stuff far too late. And so then it feels like a tug of war when in fact it's still the same system. Different people have different strengths. And I think you can be efficient administratively, even as a clinician, as long as you know that you have the agency to do that. Linked to that is the patient care experience, as you're saying. But that's something that can be taught, and that's something that can actually be instilled across. So undergraduate training a lot, medical legal training, all of it, like undergrad, has to be a really clear focus and capacitating people for what they're going to experience. I think that's my biggest. If we could just focus on undergrad training in a way that prepares clinicians, they support. So I mean, even our interns now support the digital things. Whenever we say, "Oh, there's a digital," they're like, "Great, let's do it," And then there's still a little bit of hesitancy. But if they are able to support their heads of departments and their consultants and their et cetera, it's easier, If they know that, oh, no, I'll take care of this, I'll do the numbers, I'll do the whatevers, then the head of department, etc., isn't thinking about the heaviness of the admin, but the younger interns or the comserves are able to, because chat, come on, everyone's just there. It's easy to move information. And so I think that and providing these iterative leadership lessons. Everyone's a leader in the health system. Everyone, whether they use that knowledge or not, or exercise that authority or not, is something else. But yeah, I think if you know about resource management right at the beginning, same way lawyers and accountants are very clear about how, they have to be able to manage resources as soon as they walk out of fourth year or out of their articles. That has to be a part of the strength of undergrad training. It cannot be that we're dealing with just a human body physiology and maybe a little bit of social medicine now and again. So my magic wand would really be, let's start where we are, let's start with the undergrads, etc., and let them support the shift that has to come with this move, with this whole ecosystem, that they are able to then do the thing of itemized billing. There was one swab to do this, there was one what to do that. Our HODs really, they don't have the time even, because they're busy trying to pass people, specialists as well as undergrads, and they're going to meetings and they're going to present at conferences. So I just think, knowing what I know and what I see, we can deal with, I think there's more flexibility in our younger, colleagues across all clinicians, you name it, dietitians, everything. So I think the biggest lever is actually there.
And also that will identify different talents and interests earlier on in their career. Nobody needs to know the indications for partial gastrectomy in 6th year, but if you're good at data management, it can be taught and it can be useful to people. If you're good at computer systems, if you're good at leadership, etc., etc.
Absolutely.
Like, sort of, what job are you actually doing for the client and how you are actually helping them, essentially.
Exactly. You just need to know, is this person in the right place at the right time for this thing? Yes, no, great. That's a helpful thing for people to know. Like, is this person here? Is this person supposed to be here? Yes or no? And if not, who is this? And how can I help facilitate that in a way that's helpful for the family, for the department, for etc., so that there's no unnecessary waste. But everyone can make that decision. I think everyone has the capacity to make that assessment, but we have to empower people to be able to do so, and then to say, okay, now that I know that this person doesn't need to be here, how do I support? Let me write the right referral. Let me write to the right person. Let me tell them exactly what needs to happen, and if there's any problems, who to contact. And here's my number, and here's my MP number, just in case. But anyway, I could go on forever around that. But that's where I think the greatest investment can be made. Yeah.
Thank you so much for joining us, Tshego. And I really enjoyed that chat, and I'm sure a lot of people listening will take a lot of value and insight from it. So thank you so much.
Oh, awesome. Yeah, this is great. And I'm glad that you've got this platform. Dan, keep doing what you're doing. Having people talk, I think, is part of the solution. You're part of it, and in our own sort of ways, we all sort of figure it out. But it's great that you're creating a platform for people to discuss this, to think about certain areas in their area of influence. And let's hope that takes the conversation further. Thanks so much.
So that is all for this month's episode. As always, please like and subscribe and share with your colleagues. You can get it on all of your main platforms. And if you would like to get in touch, please send me an email on dan@badem.co.za. And please visit our website, www.badem.co.za, for lots more content. Thanks so much for listening. We'll see you next time. Bye.